Welcome to this new series, ABGs with PKJ. If you work in the intensive care unit, chances are that you have dealt with blood gases. Like ECGs, ABGs are extremely useful diagnostic tests when managing patients who are critically ill. But for the inexperienced resident doctor and maybe even the junior consultant, ABGs can be intimidating. They need not be. In fact, a proper systematic approach to this blood gas interpretation is really very easy and can prove extremely useful in the management of sick patients. These vodcasts are downloadable and can be freely distributed provided they're used for personal, non commercial use and for academic purposes. Feel free to distribute them. The best way to use these videos is to pause them in between, especially when a problem is presented. Draw your own conclusions and then play the video again to hear my interpretations. I am fully aware that there are many variations in the approach to blood gases, and different institutes and different countries may teach different approaches, and that is fine. The important thing is to get the most out of a blood gas. This blood gas was submitted by Dr. Alpna Kumari, who is doing her fellowship in critical care medicine from Moolchand Hospital, Delhi. This is a part of a requirement for the fellowship program. A 75-year-old lady with diabetes since 20 years was transferred to her hospital from a nearby nursing home where the patient had been admitted for fever and cough with expectoration. Patient was tachypnic and drowsy, and a blood gas was done soon after admission. How would you approach this blood gas? The important thing to do is not be tempted to just start looking at the blood gas without paying attention to the history. Let's keep the blood gas aside. Looking at the history, this is an elderly lady who is tachypnic and drowsy. She may have respiratory tract infection or pneumonia, and therefore there could be problems with her oxygenation. She's tachypnic, could be hyperventilating. In terms of acid-base abnormalities, being diabetic and having an infection, it's possible that she's in diabetic ketoacidosis. Having thought of that, now we go on to look at the blood gas. When approaching a blood gas, it's very important to categorize your interpretation into three distinct categories. First, the oxygenation status. Second, the ventilatory status. And third, finally, the acid-base status. Having done this, it would be meaningless if we could not sum it up into a clinically meaningful diagnosis that would help in patient care. To comment on the oxygenation status, one looks at the PaO2, keeping in mind the FiO2, which is the fraction of inspired air, which is oxygen. In this 75-year-old lady, a normal PO2 of 80 to 100 is expected. 75.7 is not too bad at this age. So, though this lady has signs and symptoms of a lung infection, I would not expect a serious pneumonia. With regards to a ventilatory status, we look at the PCO2. The normal PCO2 is 35 to 45 millimeters of mercury, and so this lady has a value which is in the normal range, and at face value, she seems to be ventilating adequately. In the interpretation of the acid-base status, one first looks at the pH. This is acidemia. So there has to be an acidotic process, either a respiratory acidosis or a metabolic acidosis. The PCO2 appears to be normal, but the bicarbonate, which should be 24, is very low, and therefore there is a metabolic acidosis. The moment you get a metabolic acidosis, you must classify it into increased anion gap or normal anion gap acidosis. This is also called HAGMA, high anion gap metabolic acidosis, or normal anion gap metabolic acidosis. And the way you do that is the anion gap is equal to the sodium minus the chloride plus bicarbonate, which in this case is a sodium of 136 minus a chloride of 109, and add to that the bicarbonate, which is around 14. This gives us an anion gap of about 13. Normal anion gap is about 12 plus minus 2. So this appears to be normal. And this is the biggest mistake that you could make. Normal anion gap is 12. And so when you get the anion gap in the patient, do not compare it with this 12, especially in the intensive care unit, but compare the anion gap actual with the anion gap expected. What is the expected anion gap? The expected anion gap is equal to 12, to which you apply the albumin correction, plus to which you apply the pH correction. What is the albumin correction and what is the pH correction? Since the albumin value is not given in this case, let us skip this. What is the pH correction? If the pH falls, the anion gap falls. If the pH increases, the anion gap increases. But by how much? If the pH falls, which means that there is an acidemia, the anion gap decreases by -2 in acidemia. And it increases by 4 in alkalemia. So in this case, because the pH is 7.14 acidemia, the expected anion gap will decrease by 2, and therefore the expected anion gap here in this case is 10. So the anion gap here is 13. The anion gap expected was 10, and therefore the delta anion gap, which is the difference between the actual anion gap and the expected anion gap, is 13 minus 10, which is 3. So this patient has a high anion gap metabolic acidosis. Now, when you diagnose a high anion gap metabolic acidosis or a metabolic acidosis, the first thing you should do is check compensation. How do you do that? In metabolic acidosis, the bicarbonate falls, and therefore the PCO2 should also fall by the same amount one time or 1.5 times. In our patient, the bicarbonate from 24 has fallen to 14, that is by 10, and the PCO2 should have also fallen by 10 to 15. So the PCO2 expected would be between 25 to 30. In our patient, it is 43, which is a very high value, which means that it is increased and there is an associated respiratory acidosis. So our patient has got a metabolic acidosis, which is a high anion gap metabolic acidosis, plus we have just seen there is also a respiratory acidosis. Is that all? Whenever you get a high anion gap metabolic acidosis, and we know that the delta anion gap was 3, you must look for hidden disorders. And to find out hidden disorders, you must calculate the corrected bicarbonate, which is equal to the actual bicarbonate plus the delta anion gap. If this value is 24, there is no hidden disorder. If it is more than 24, if it is more than 24, there is associated metabolic alkalosis, and if it is less than 24, there is a associated normal anion gap metabolic acidosis. So what do we see in this patient? The corrected bicarbonate in this patient is 14 plus 3, that is 17. It is much below 24, and therefore this patient also has normal anion gap metabolic acidosis. So in terms of acid-base abnormalities, our patient has a high anion gap metabolic acidosis plus a normal anion gap metabolic acidosis plus a respiratory acidosis. So now to sum up into something that's clinically meaningful, we see in this case that the oxygenation isn't bad. The ventilative status, which initially appeared to be normal, is actually the patient is hypoventilating, and that is giving rise to the respiratory acidosis. And in terms of the acid-base status, there is a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis in addition to the respiratory acidosis. Why is there a high anion gap metabolic acidosis? Well, the lactates are elevated, but this patient who was a diabetic with infection, actually the blood sugars were very high, in the high 700s, and they were ketones positive. So this patient has actually presented with diabetic ketoacidosis. What is the cause of normal anion gap metabolic acidosis? Most certainly, it was the result of the normal saline that was being given to him, causing a hyperchloremic normal anion gap metabolic acidosis. So this is how one would approach the blood gas. I hope you've learned something and enjoyed it. Before I go, something that's important. Why the respiratory acidosis? Now that's interesting. Why is this patient having a respiratory acidosis? Yes, it's interesting, and something that's not well appreciated is that this patient doesn't have COPD, doesn't have any other reason to be hypoventilating, but you look at the potassium, and though it appears to be normal, in the presence of acidosis, there is always pseudo elevation of the potassium, and this is predictable. What actually happens is, in the presence of acidosis, this is in the intracellular part and the extracellular part. In the presence of acidosis, there are a lot of H ions outside which go into the cell to bring about a reduction in the acidosis. And to compensate for this, potassium moves out of the cell, causing an elevation of potassium. As soon as the acidosis is corrected, then this is reversed and potassium goes back into the cell. So what is the corrected potassium in this case, and how does one calculate it? For every 0.1 drop in the pH, there is an elevation of potassium by 0.7 or 0.8. So in this case, the pH is 7.14. It's dropped by 2.5 units, and therefore the potassium is falsely elevated by 0.7 into 2.5, which would be, so the potassium is elevated by 1.75 to 2 milliequivalents, and the corrected potassium therefore is somewhere between 2.8 to 3. That may be contributing to the respiratory weakness. Hope you enjoyed this. There are many more videos that we will be uploading, and piece by piece you would learn more about blood gas interpretations. If you want to learn more formally about the approach to blood gas interpretation, you can listen to the lectures available on www.icueducation.com. See you next time.